Hello, Mac. Nice to see your
Here,
face.
here we are again. What a wonderful time. This is great. Loving it. Loving it.
Here we meet.
Let's open up. Come on.
Let's
Tell
do
some
it.
deep, dark secrets.
Ooh, I like it. This one seems like
Only in dentistry.
it's,
Only in dentistry. Just dentistry.
yeah, we can't share we can't pull out all the skeletons, right?
Not yet.
Just the ones involving the TM joint, right? And the skull.
Let's stay focused.
All
Okay.
right, all right. Let's refocus. Let's open up. I want to share a story about a patient of mine. Her name is Kelly. I just saw her last week. But anyway, we alluded on our last podcast that we're going to talk about, clicking, popping joints and also trigeminal neuralgia, also known as TN, right? And Kelly came to my office many years ago. She had the surgery that's involved with trigeminal neuralgia, which I'll talk about a little bit more later, right? It was the one where they actually cut or made a window through the base of her skull and repositioned the artery off the nerve. But we'll talk about that more. Anyway, she's got that beautiful scar on the back of the neck, and I believe she went to NIH. And anyway, like we've talked about before, I'm the 10th doctor down on the list, way, way low. And she found us because she had been to everybody, was on all kinds of medications to mask her pain, dull her biofeedback to her body. And the last thing she had done was the surgical procedure for TN, and which made her feel fine for about 8 months. And then all the pain symptoms she was having, the chronic migraine, headaches, the severe pain she'd have around her masseter insertion around this cheekbone area. But anyway, she was just in chronic pain. She has 2 daughters and was trying to hold a job. It was affecting her in every way. So anyway, I treated Kelly originally. I treated her with orthotic treatment, and I wasn't really sure when anybody's had the surgery with of that for the trigeminal neuralgia. They're harder to treat because their body doesn't always respond the way that I would anticipate it to, because of the impact on the nerve itself. And anyway, we treated her with orthotic treatment and she responded amazingly well. And I did not want to do any orthodontic work on her. She wasn't a candidate for porcelain crowns because she had perfectly healthy teeth. She had had a history of having braces 2 other times. The first time they had pulled 4 of her teeth, her premolars, which are the middle teeth in our mouth. And that right then is what, once they retracted to close up all the spaces, pulled her jaw back. And since then, she slowly started to have symptoms throughout her life. But anyway, I had her in orthotic treatment for a year, and she responded great and stayed stable for quite a long time. And she's like, I don't want to wear this appliance. She was in her late 30s. I don't want to wear this all the time. What's my other options? I was like, orthodontic treatment, but just be aware that through treatment, because while things are moving, you can backslide. You can start to have some of your symptoms can resurface. You'll never go to ground zero again. I felt confident at that point because it had literally been almost 12 months and she had been doing so well. And so we cautiously both agreed to move forward with orthodontic treatment. And Mac, she's doing extraordinarily well. Like it's been, I want to say like 7 years. I see her just, for recare, comes in for cleaning. I also see her just once a year to check the joint, check her muscles. Because of the damage to the joint and the nerve, she can regress and have episodes if she's not taking care of herself. It's like having bad hips, I can get your hips working right and your muscles working great, but some of the damage has been done in an adult, right? So you've got to take care of yourself. Otherwise, you'll get triggered. Never back to zero, but get triggered. But man, she was so grateful for the treatment. And, again, just sad that she had been through so much and had suffered for so long and was incorrectly diagnosed. Again, some of it, no disrespect to other colleagues because they might not know, but they don't know. But I'm curious, like, how can you perform treatment on some people when you don't know how to actually analyze all aspects of that condition, right?
Right. And so in everything we do and MDs do is that you have to have a differential diagnosis. Differential diagnosis meaning, is it TMD? Is it trigeminal neuralgia? Is it migraine? Is it cluster headaches? those are all supposedly separate entities, and I'm sure they are. Okay, so I have asked neurologists before, because they're the ones responsible for diagnosing migraines, which is the same symptoms as your TN, not necessarily, because TN's got all of the skin issues, but everything's so similar. Okay, so let me ask you this. If you had an exposed nerve and you pressed on that nerve, what would happen?
Mhm. It's gonna
Yeah,
hurt.
you're gonna hurt.
Right.
Okay. So the root of the trigeminal nerve, which operates not all sensory, but almost all pain in most of the sensory of the face, makes the five fingers like we talked about in the first episode. Every pain that you have in your face is due to the trigeminal nerve. You can just basically. So trigeminal neuralgia is a pain in the face. Okay, so because it's a pain in the face, they seek medical treatment.
Right.
So you mentioned a misdiagnosis several years ago. It was a misdiagnosis. Now, if a neurologist or MD who's responsible for diagnosing trigeminal neuralgia, migraine, cluster headaches, has no education, they're completely unaware of TMD other than a clicking joint, how can they possibly make a differential diagnosis?
Right. God, that's such a good point.
Or an MD who is often wrong but never in doubt, who diagnoses all headaches as migraines, or severe headaches is trigeminal neuralgia, when the trigeminal nerve passes right by the joint and can be squeezed and irritated and inflamed
Mhm.
by a bite that is not in harmony with a
That's right.
person who is sensitive to things other people are not sensitive. And sensitivity is sex, it's hormones, it's a lot of things, it's stress. It is truly a biopsycho social issue. Bio is the mechanics of the mouth. Psycho is where am I in my life? Am I stressed out? I mean, what my kids are doing? And social is can I pay for it? Do I have family support? All of these things come into play no matter what. If it's TMD, if it's TN, trigeminal neuralgia, migraine, or cluster headaches, it all comes to play with the diagnosis. But if you don't know all of these conditions, how can you possibly do a differential diagnosis?
Uh, Beautifully said. Beautifully said. And for our listeners, um, trigeminal neuralgia anatomically, specifically, is the compression of that trigeminal nerve, which is one of our 12 cranial nerves. This nerve is a sensory nerve and a motor nerve. Sensory meaning, like Mac was just saying, it depends on the literature, 70 to 80% of our feedback to our brain about what's going on and with our face, where our body is proprioceptively, meaning spatial relationship. And it also controls the movement of a lot of our jaw chewing muscles, our masticatory muscles, and facial, some expression muscles. But anyway, this is a huge nerve. And anatomically, if it's compressed by an artery, just because of the position, that is what causes trigeminal neuralgia. Anatomically, that's what causes it. Now, the symptoms that come from trigeminal neuralgia, like Max said, are very much under the same umbrella of TMD. So it can be easily misdiagnosed if you're going just based off of how someone's feeling, their symptoms, right?
Right.
So there are three ways the medical profession, I believe, there could be more now, I don't know, but there's three ways that they're treating them because I've seen a lot of their post-operative patients for treatment. One is the one I was just telling you about, Kelly, where they do a surgical incision right behind a patient's ear. They make a hole through the base of the skull, and they actually reposition that anatomy to get the compression off the nerve. Because it's like you said, it's not that the nerve is exposed, but if you're pushing on a nerve, that hurts. It hurts to the point that even if wind goes across their face, it's like electricity. It's like their face is on fire. That's totally different than a TMD issue, right? So that's one
Absolutely.
way to do it. The other way they do it is through microvascular decompression surgery. I think it's MVD is the acronym for that. And that's less invasive. They don't actually go in there and surgically make a hole and move things. They use radiation beams to kill parts of that nerve, the trigeminal nerve. It's aimed at that nerve specifically to damage it. So it stops the transmission of pain signals to the brain. And then the third way that I've seen more recently is rhizotomy, where it's very similar to MVD. They're just doing things to, again, damage part of the trigeminal nerve to stop the biofeedback to the brain. And I don't think I think they know they can't do too much to that nerve because of all the feedback it gives to the brain, the important feedback, and also the function of our jaw and chewing. So they're very limited in what they can do. And while people might have some numbing of the nerve and feel better for a while, if it's a true TMD issue due to a toric mandible, midface deficiency, or posterior interference, is what we've talked about, then the symptoms are going to go back and they've already suffered that procedure in vain, you know? So that's one of my biggest frustrations, my friend, is like just people being incorrectly diagnosed, maybe because the doctor just didn't have the time to spend with them and listen to them, like you always say, or they just didn't know what they didn't know.
Yeah, and so I go back to 1968, sitting in an anatomy class and learning about trigeminal neuralgia. And back then they did a surgery. So, and again, I'm not an MD and I've been away from all this for a long time. But isn't it true that they treat at the foramen part of the brain where the nerve comes out? At least that's what they were doing back in 1968. So there's a difference between the nerve coming out of the brain versus the pressure that's occurring here. Now, trigeminal neuralgia is real, and the diagnosis is extremely important. But because there's a vast awareness of TN, because it's been around so long and it's so painful, there's not an awareness of TMD worldwide. So again, the physicians are going to have to learn to do a differential diagnosis between TMD, as you said, because it'll reoccur, TMD or TN. And both of them are individual systems that do cause pain.
You know,
I'm calling for awareness. That's all I'm calling for, just awareness
yeah,
for.
it still dumbfounds me why the two professions, why we can't collaborate and have conversations to take care of people globally. It's like, I'm not pretending to know everything that a neurologist does. That's way past me in many levels. I get and respect that. But, why is it that they know nothing about the mouth and the way the teeth fit together? It doesn't take rocket science or many years of education for you to look at somebody's mouth and see if their teeth are all jacked up. Then there could be a masticatory issue causing TMD that is causing some of these problems. Why can't we talk about these things? Man, don't now you got me going.
Good.
It's like
Open up.
man, this week, oh man, I'm probably gonna be in so much trouble on this one. But the ear, nose, and throat doctors, they're freaking killing me. They're killing me. I'm treating all these children because they have airway issues we've talked in the past, and I'm trying to like stop this horrible craniofacial development they're on the path towards, but they have giant tonsils, giant adenoids, and they have their turbinates are all swollen because they're allergic to everything under the sun. I send them to the ENT with an eval, with a radiology report, with a copy of my 3D scan that they don't open up and they don't bother to read. And they tell the parent, here's some Flonase, everything's going to be fine. And they're going to grow out of their freaking tonsils and adenoids. And then the parents come back looking at me like I've got two heads. And I'm not going to sit there and argue against our medical colleagues. But
No.
man, what the hell are we doing? I don't get it.
So when they being whoever, another dentist, another ENT physician, are looking at a cone beam, and a cone beam shows you joint position, it shows you the bone, it shows you the relationship of the condyle to the skull. And when that condyle, which is supposed to be rounded, is changed in shape, changed in morphology, they diagnose it as arthritis. How can you do a differential diagnosis between arthritis and compressed joint? A compressed joint, compressed bone is going to change in its morphology.
Yes.
And when you have an incorrect bite where the jaw goes backwards for many reasons, and that joint is compressed, it is going to be remolded,
Right.
reshaped, eaten up. On the
Mhm.
x-ray, it looks just like arthritis. So how does an MD differentiate, or an oral surgeon, or anybody else in the world, how can they differentiate between arthritis of the joint or compression of the joint, which causes bone destruction?
Man, it, I don't know. I can tell
Getting you
you.
fired up. I'm
Yeah,
getting you fired up.
because we only have so many hours in the day. And all of our lives are busy, but no matter what, that 24 hours never changes, right? But
Right.
I've had at least a handful of calls and meetings with different radiologists that look at the information that I'm sending them, and then they say that it's arthritis, or they say that it is stable degenerative joint disease. Okay, even if you don't have a medical or dental degree, in the English dictionary, degenerative means it's an ongoing
Yeah.
degenerative condition. So how is that stable? Like my patients even laugh at that. They're like, what do they mean by stable degenerative joint disease? Why are they using this terminology? Because it's just completely confusing and quite frankly, inaccurate. But it's exactly what you said. If every joint is like a ball in a socket, right? And we know that bone will change with pressure. So if I put my finger on your shin bone and let it sit there for 3 months, you will eventually get an indentation of my finger because of the constant pressure that's there. And because that lower jaw is a free floating swing with the ball, the condylar head, okay, if it is pressed up and back because the jaw is retruded, it's compressed up into the base of the skull, it's going to change shape. And because the body naturally wants to give you some kind of balance, on an image, it looks like, oh, it's perfectly positioned in that socket space. It's concentrically or even space all around that ball is concentrically positioned, so it's stable. That's not stable. It's because it's changed. So you have to look further. Well, the neck of the ball is bent, or the ball doesn't look like a ball. It looks like a bird. It has a beak. And we see this all the time. How can we define that as stable? Can we open it up about the stupidity of that terminology?
So in high school, I heard about this
You're not
guy
allowed.
went to the patient and says, "Doctor, it hurts when I raise my arm like this." And the doctor says, "Oh, quit raising your arm." So if everybody will make a C with their left hand
Mhm.
and make a fist with your right hand and put the fist into the C, and if you have your fist positioned where there's space all the way around it, that is a decompressed joint. If you push your fist against the C, that is a compressed joint. So when the patient bites down and the condyle goes back, that's compression. So what do? You make an appliance that allows the jaw to come close where there's space, normal space between the joint and the socket. It's not rocket science.
Can I add to that? So the clicking thing that people hear and they're like, oh, I've always had it. Well, of course you had, because your jaw never came in the right place. It's compressed up and back, like you just demonstrated with the C. So on top of every joint, ball and socket, we got that. And there always has to be something that lubricates between the two bony masses, because you cannot have bone on bone. There has to be something. And in the TM joint, there's the TMJ disc. This disc, by definition, going back to English dictionary, a disc by definition is round, okay? Because it's supposed to sit on that round ball. And in the middle of your TM, the disc is thin. It's like a lifesaver. So it sits perfectly on top of that ball, like this hat that sits perfectly on your head. But when the mandible is retruded, so again, that ball is pushed up and back, that C area is compressed. Well, that disc can't sit on the ball perfectly. It's either slid in front of it, to the side of it, in the middle. It doesn't matter. It's dysfunctioning. So now when the mouth opens and closes, that disc that used to help glide that movement so naturally and freely doesn't do that anymore. The disc is getting pinched. So when you open, it gets pinched and it goes click. And when you close, click, click, click. And then over the years, you're like, oh, my clicking's quieter, or it went away. Well, that's great. But guess what? That disc is perforated or it's torn. And that's why you don't have that noise anymore. But you'll see that difference like we demonstrated before. The mandible, the lower jaw, when you open and close, doesn't go up and down straight anymore. It can wiggle side to side because the disc
So,
is not where it needs to be. Wait a minute, I'm not done. Or it can just go off to the side, or you can have limited range of motion. Okay, now I'm done.
so a visual is edamame.
Edamame.
You bite into the edamame and the bean pops out because it got squeezed out.
That's
You know,
exactly.
the disc gets squeezed out. It may go in front, may go to the side, may go left, may go right, may go back. It gets squeezed out.
Mm.
And when you get it at the right time, you can put the edamame back into the pod. But if you wait too long, you're not going to be able to get it back in.
I hope all these amazing analogies you're using are going into your new book because you are just so great at depicting words into making people understand it and visualize it. You, like I said, you're the Yoda of communication.
Well, thank you very much. Let me say something about the book. I've got one on Amazon, you do too. But you can just type my name into Amazon for the listeners and sign up to me as an author. And when the book is published, you'll get notified. But yes, Pam, every single thing that we've talked about so far in all of these podcasts are in the book. And
Am I going to get a cut of the action then?
I'm gonna send you a unedited rough draft
I'd love
to
it.
get beat down by you. No, I know you're not.
I would love to read it. You know that. All
But
right.
it's got great information. Everything we've covered is in the book. Yeah.
I think I had an extra shot of espresso in my coffee this morning. I hope that wasn't too heated, but we told everybody from the beginning, this is about opening up to, seeing people differently, maybe for the medical profession, dental profession to consider the way their business model is to allow for more time to spend with their patients and listen to them so they can help guide them if they don't want to or know how to treat them. Because you know as well as I do, this is a true epidemic. TMD pain that's also directly correlated to obstructive sleep apnea. This is,
Yes.
it's massive and there's not enough people that know. And I hope people are hearing this and getting the word out there.
Well, our enthusiasm is maybe we're a little bit too over enthusiastic, but I don't think so because this is way too important. And while we're laughing and everything else, we realize that you people in pain are suffering. And we're doing our dead level best to bring awareness to help you find answers to your solution, not only for you individually, but worldwide. So
Please reach out to us or leave comments if we need to be more specific or be more depictive in our words. We do put this on YouTube because sometimes we're demonstrating things, we're trying to verbalize it, but reach out to us. Mac and my team are constantly reading those comments. So let us know. What are we going to talk about
yes,
next, Mac?
the different appliances.
Oh, there are
Well,
a ton of appliances. This should
so
be fun.
we can really raise some stink on the different appliances, who uses what and why and what works and what doesn't work in our experience.
I can't wait. All right, I'll
All
see you
right,
soon.
sounds good.